So go to slide share. Very good afternoon, and I thank organizers for inviting me to this very, very good conference that's going on. And the presentation that I'm going to do today was accepted for oral presentation at International Congress of Endocrinology 2021, and that was held in February on a virtual platform. So my topic was effectiveness and durability of extended release Gliclazide in the treatment of type 2 diabetes, a real world perspective. So I'm using the same slides, so it might be interesting as well. So it's ICE 2021, and this is the hospital where I work, Apollo Hospital in Calcutta. Now, before I present my paper, I think it would be imperative that I give some introduction to the modern sulfonylureas. Remember, most of the criticism of sulfonylurea stems from the older generation of sulfonylurea. So if you look at Gliclazide, on which my paper is, the sulfonylurea receptor has many subunits in KATP channel, and they have got variable affinity to the sulfonylureas we are using. Gliclazide here has got more susceptibility for ACUR1, but it does not bind with the EPAC2, and that is more responsible for vigorous and aggressive exocytosis of insulin. Therefore, there's a reversible binding and a pulsatile nature of secretion of insulin and less hypoglycemia. If you look at glimepiride also, then we know that it only inhibits the sarcolemmal KATP, and it does not affect the mitochondrial KATP channels in the myocyte. And that is the reason that this modern sulfonylurea does not affect the ischemic preconditioning or the cardiac safety in our patient. The normal myths and facts of use of modern sulfonylureas are many. Most of them are arising from our older generation, and these are hypoglycemia, weight gain, beta cell exhaustion, durability of glycemic control, and of course, other than durability, is cardiovascular profile, cardiovascular safety to be more accurate. So as I go down my slides, I'll try to show evidence and refute these criticisms with the modern sulfonylurea. If you look at the ADA ESD guideline of 2020, then what you will find is there's an oversimplification of the usage of Gliclazide. What it says is it is put under the heading of cost. Undoubtedly, cost helps. But I think if you look at the efficacy and durability, and if you take in context of our prescription in our practice, then you and I agree that if somebody comes to you with an acute hyperglycemia of age 10 or above, and if the patient is asymptomatic, if the duration of diabetes is not long, say within 5 years, so there's a reasonable insulin reserve in the patient. And if you are thinking the patient doesn't have osmotic symptoms and catabolic symptoms or weight loss and things, then you can very jolly well get away with the standard of practice plus a sulfonylurea to get your HbA1c down. But there is no controversy if those 10 years down the line, if the patient is symptomatic, and if the patient has weight loss, or if the patient has got severe osmotic symptoms, you would use insulin, that we all do. When we are talking of a molecule today, we are talking of a molecule that is only next to insulin in terms of efficacy. If you talk of hypoglycemia, I have got a small caveat that the gold standard of diabetes care is insulin, and the maximum hypoglycemia is caused by insulin. So an intelligent use of any of the molecule and individualizing the care will definitely give benefit to the patient, and I think there will not be undue nervousness about the modern sulfonylureas. Now let's go to some of the evidence regarding weight neutrality. There's a lot of talk about weight gain. UKPDS used an older generation of sulfonylurea. There also weight stabilized in that long study by 3 to 4 years. If you look at Accord, it is interesting that the intensive group had more of the weight gain rather than the standard group. VADT and mode of Rosie and other things to blame. If you look at the advance as my model, It is almost 11,000 patients, 11 to 12,000 patients. And something between 8 years to 14 years of duration of diabetes, 91% used gliclazide. And on the top, 40% used insulin. Was there a weight gain? Negligible, insignificant. So therefore, only a 0.5 kg. If you look at these data, then you will realize, and if it's a 0.1 kg most of the cases, which is 100 grams. So if you think of the weight gain, and that would happen with gliclazide plus insulin, with a diabetic between 8 years to 14 years duration, then I think we reasonably refute the myth or the concept that gliclazide or modern sulfonylurea will be causing the weight gain. Therefore, sulfonylurea like gliclazide XR did not lead to significant weight gain in the long term. That was our understanding. If you look at this paper of the diabetes, obesity, and metabolism, no significant difference in weight gain in metformin plus glimepiride group. And this was a strict glycemic control can be maintained. And of course, they also showed in the Zodiac study that it is not necessary that it is true that it can cause hypoglycemia, but as long as you use them intelligently with all the patient education, I think the chances of weight changes is negligible, as you can see in this diabetes, obesity, and metabolism. Another severe criticism is about beta cell exhaustion. So we keep saying that in sulfonylurea is a cause of beta cell exhaustion, but have we got any evidence really? I strongly believe we don't have, definitely not for the modern sulfonylureas. Rudy Holman said that no solid evidence of beta cell exhaustion in the clinical setting over 6 years in the UK PDX. Diabetes itself may cause decline in the beta cell function, and beta cell exhaustion, is there any difference with this? I think it is a very interesting thing to say that it is a sweeping statement most commonly to say that beta cell exhaustion happens. But if you look at the way the modern sulfonylurea binds to the sulfonylurea receptor, and the way in advanced study they used up to 14 years, and they were 91% on sulfonylurea, modern sulfonylurea, gliclazide, and there was no question of exhaustion. I'll come to my paper as we go along. So one of the very, very interesting paper that I pulled out was this one. What they did is they tried to, in vitro, they put the pancreatic cell line and expose them to the different anti-hyperglycemic drugs and see what happens. It is the apoptosis study. And in the vitro, they found that the control was worse than gliclazide. So then the concept came about antioxidative benefit of it. But I would of course wait for more evidence to come. But definitely this one in vitro study showed you very clearly that this is comparable or probably better in terms of apoptosis. So it will be unwise to blame gliclazide to tell that this causes apoptosis. Now, advanced is a very good model to talk of beta cell exhaustion because you had 11,140 patients. Average duration of diabetes was 8 plus 6 or minus 6. So if this group of patients had 91% patients on gliclazide and they had only 40%, 30 to 40% requiring insulin, then you can understand if this caused beta cell apoptosis, then or beta cell exhaustion, I would expect 100% of them needing insulin. Now we come to the cardiovascular part, because often many people talk about the cardiovascular safety, but all the thoughts came from the older generation. This was the Lancet paper of 2015. What they found is that all-cause mortality with the gliclazide and glimepiride on the left side of the forest scatter, so as CV mortality. So this is not 10 or 20 patients, 1,67,000 patients, meta-analysis of 18 studies. Therefore, to say that they cause, and of course I explained in the beginning that the different sulfonylureas has got different affinity for the sulfonylurea receptor subunits in the KITB channel. So it will be unwise again to tell that glimepiride and gliclazide causes cardiac adverse reaction. And of course, not after Carolina's study as well. This is Gliclazide has entered the textbook of cardiology by Bruno. I think the Danish registry was a very good example. And it has been agreed by the experts globally that this is probably a safe drug, along with the standard of practice. Now, if you look at the cardiovascular safety of sulfonylurea in randomized clinical trials, this study again took out 62 trials. And in this meta-analysis, what was the finding? Use of sulfonylurea was not associated with any significant difference in the incidence of myocardial infarction with respect to its comparator. I think that would be very reassuring to the critics of sulfonylurea. I think if you look at the EMR-based Gliclazide real-world study from UK, sometimes people do frown on real-world evidence. But my thoughts to them is that for a molecule, you need a randomized controlled trial to extract evidence. But the expression of that evidence comes in the real-world study. Therefore, they're more of a complementary rather than anti to each other. Therefore, the real-world studies actually gives you the expression of the evidence. And undoubtedly, for extracting evidence, you need a randomized controlled trial. So this again looked at versus sitagliptin. And it was found that 51% more likely to achieve target with HbA1c less than 6.5%. And of course, we do agree of efficacy part. Now, this is my paper that I specifically wanted to talk about. Now, what we did, we thought that we need to look at the durability of Gliclazide, because one of the thoughts that come across is when you are using a sulfonylurea or a model sulfonylurea, how long will you be able to continue? And does it really causes a beta cell exhaustion? We didn't study that, we studied clinically. But the point is that if you are using Gliclazide, do they actually go to insulin very quickly? What is the durability? So our hypothesis was that Gliclazide is an acceptable standard of care in the management of diabetes. And to assess the control rates and periods until the initiation of insulin from the onset of diabetes, I'm saying a durability. That is the beginning of the diabetes, and you start them on sulfonylurea, the modern sulfonylurea, and then the point in which you start the use of insulin, and the point of time of initiation of treatment. We, of course, an open level observational study. We also tried to look at efficacy. We tried to look at weight change and at hypoglycemia. So what we did is we conducted a retrospective analysis of 300 patients. We took the patient successively coming to our clinic, those who were diabetic for more than 5 years. So any patient who was more than 5 years diabetic and is continuously on Gliclazide for the patient recruited. To maintain the homogeneity, we give the standard lifestyle advice. And a longitudinal follow-up, of course, we did a study to see retrospectively up to the point of our record. So what we found was that it was a dedicated institutional diabetes care center, Apollo Hospital. The patient with the duration of diabetes, as I said, was more than 5 years, adherent to the model sulfonylurea-based regimen, that is Gliclazide extended release, and with the standard of care approach since the 2000 very well. Now, structured patient education and lifestyle management was provided during each follow-up visit. Descriptive statistics was utilized for analysis. And this is our result. The mean age of the patient we had was 55 years, plus minus 8. The mean HbA1c was 7.1. And you would agree that this was very close to the ADA recommendation. 82% of patients achieved target range of less than 7%. Although the mean for the overall population or the overall cohort was 7.1, 82% has less than 7%. 18.7% patient had diabetes for more than 20 years. I want to draw your attention to this also, that the cohort we had patients of 20 years. And almost for 13 years, the mean duration of 13 years was the patient that they were on for Gliclazide-based treatment before they went on. So durability was something around 13.1. So, and the mean duration of treatment regimen for Gliclazide was around 13 years again. 1% patient reported episodes of confirmed hypoglycemia but that was self-managed, no third party help. So what I'm trying to say, that if you do the education as normally you do in the studies more aggressively, and you tell them exactly how to do, and you are in touch with them, there is only 3 patients of the 300 that minor hypoglycemia. This is a busy slide, but giving the details. Just want to highlight one thing, that if you look at this, 5 to 9 years duration of diabetes was about 100 patients, and 200 patients of the 300 had diabetes for more than 10 years. So that is interesting to tell you that we are talking of durability in terms of a patient who had considerable longer time of diabetes. So this is important, and of course you can see the BMI wise, we had 50% patients who had a BMI less than 25. So again, the thin fat Indian, we talk of the abdominal obesity. Now we had a fairly matched male-female ratio. And of course, if you look at the age group or for BMI, duration of diabetes and insulin requirement, then also you see that we had only 18% patient, 16%, sorry, 16 to 18% of patients who needed insulin. So that is important to note. If I can put the results for your convenience, only 16.49 patients of the 300 having a mean duration of 13 years on the gliclazide-based therapy, and overall patients even up beyond 20 years were on sulfonylurea gliclazide along with the standard of care. So if there was beta cell exhaustion, then that would have happened. As for the weight neutrality, I'll come to that we had negligible weight change in our population. The number of patients of BMI was less than 25. The number of patients with duration of diabetes, as I explained, is the pie chart to have a good look at the patient. Insulin initiation was at a mean age balance of 8%. So we gave insulin if there were more than 8%. So you can see beta cell exhaustion, weight gain, and hypoglycemia, we have refuted. And in our study, we could establish the durability. So the conclusion was, we observed a sustained glucose lowering attributed to gliclazide-based approach demonstrated by majority of the patients, which enabled to postpone insulin initiation despite a long duration of diabetes without compromising glycemic control. Overall, the patients achieved a glycemic level close to target 7%. Our findings support sustained glycemic control for durability with potential to postpone insulin initiation attributed to extended release gliclazide or modern sulfonylurea. Needless to say that you will individualize the patient and treat appropriately. But what I'm trying to bring forth is that it is an oversimplification to talk of modern sulfonylurea only under the cost, and you must remember the Carolina study as well. To sum up, the treatment of patients with type 2 diabetes is always individualized. Evidence and clinical practice have confirmed that SUs are the mainstay of the management of type 2 diabetes in vast majority of patients. All SUs should not be considered as one. There is intra-class difference in industry. Modern SUs are effective and safe if used intelligently. If you are still not convinced, cost is also very important. Thank you very much.
Okay.